Okay, and we're back to talk about sweat duct tumors. So, this tends to be one of the trickier topics, I feel like. So, we'll go through everything that's high yield. So, in this one, we have these islands of basaloid cells that are kind of fitting together like a jigsaw puzzle, and they have a little bit of eosinophilic cuticle in between them. So, there's only one thing that looks like this, and it's cylindroma. So that's when it has the jigsaw pattern, and then they have that basement membrane around them, which is type 4 collagen. They're frequently on the scalp, and they're apocrine in origin. So you can see multiple of these in Brooks-Spiegler tumor, or sorry, Brooks-Spiegler syndrome, and then you can also get a malignant form of this cylindrocarcinoma, which basically is more poorly differentiated with aggressive behavior. Okay, next one. So this one again is basaloid cells, but it's just forming like one big nodule, but you have a little bit of like eosinophilic cuticle kind of in the middle of it this time. So this is a spiradenoma, and then there's also some lymphocytes peppered in there too. So they have the eosinophilic hyaline droplets in the islands, and usually it's solitary. But this too can be associated with Brooks-Spiegler syndrome, and they just present as a solitary painful nodule that favor the upper half of the body. So this brings us to our tender tumors. So this is a mnemonic that can help you remember it. So blue rubber bleb nevi, angiolipomas, neuromas, glomus tumors, leiomyomas, and spiradenomas, which is ecrine spiradenomas, but it's actually apocrine derived. And these are tender because they have smooth muscle that can contract, or they are related to nerves, or because of inflammation. Okay, next one. So this is what we call Ford's and Franz kind of pattern, and it's coming off of the epidermis, which I know it's hard to tell here. And then if you looked up close at the inflammation here, you would see plasma cells. So this is a syringocystadenoma papilliferum. So it opens up into the epidermis. You have the Franz and Ford's kind of pattern, which look up what those mean if you aren't sure, because it has nothing to do with dermatology. It has to do with more like nature. And I'll give you an idea of what you're looking at. And then you also see plasma cells in the peritumoral stroma. So they can be present at birth or early childhood. Sometimes they can be associated with nevus sebaceous, and malignant transformation is really rare. Okay, next one. This one also has that decapitation secretion, which you can see here really clearly. And this one looks the same for the most part, except for it doesn't connect to the epidermis. So, when that's the case, it's a hidradenoma papilliferum. So same thing, you have the fronds, but there's no epidermal connection, and these are most commonly on the vulva, usually the labia majora. Okay, next one. So again, this kind of has like those papillary fronds in here, but they're like really dark cells with very little cytoplasm. And this is usually on the finger of somebody. So this is a papillary digital carcinoma. So it's a blue tumor with cystic change, little to no cytoplasm, papillary fronds. You may see mitoses or necrosis as well. A lot of times it's in young people. And they're really highly aggressive. So even if you amputate the finger, there's a 14% metastatic rate. And it can be in middle-aged adults, and you just treat it with amputation, which is unfortunate. Okay, another one of my favorites. So you have these blue basaloid islands that are sitting in a sea of mucin or snot. People like to say blue islands in a sea of snot. There's really nothing else that looks like this, which is why it's one of my favorites. So this is mucinous carcinoma, and it can be primary or metastatic. It kind of looks the same. It stains CK7 positive and CK20 negative, and you get the cribiform appearance. So very rare, most commonly on the eyelid or periocular region. It can be either non-neuroendocrine or neuroendocrine. Treatment of choice for this is Mohs. And then usually when it's on the face, it's primary, but Other places, like on the trunk, it can be metastasis of visceral malignancy. Okay, next one. So this is again our tadpole or paisley tie differential, where we have these little tiny sweat ducts that look kind of like little tadpoles, if you really use your imagination, and you have a pretty sclerotic stroma around it, and they're pretty well defined. Like the lesion itself is pretty well defined. So this is a syringoma. So you have sclerotic stroma, and then you have the little tumors that are small and round that have little tadpole-shaped ducts. So clinically, these are just little clear papules or skin-colored papules that are mainly around the eyes, but also other places. Um, if you get eruptive syringomas, this is associated with certain ethnic groups, but also in Down syndrome. Um, and then the malignant counterpart is more of an infiltrative growth pattern, and that always arises de novo, not from a pre-existing syringoma. Okay, next one. So this one looks kind of the same, like you have your little ducts, but they have clear cells around them. So that just means that this is a clear cell syringoma, which this is associated with diabetes. Okay. So this one again, we kind of have like those little ducts forming, but we also have some that kind of look more like hair follicle type stuff or like basaloid cells. And then it's even invading this nerve here. So whenever you're invading a nerve, that's not good. So this is microcystic adnexal carcinoma. So you get sweat duct-like areas and hair follicle-like areas. Again, it's in the Paisley tie differential. And it's deeply invasive, and you sometimes get little lymphoid aggregates, and it can extend into the nerves. So it's locally aggressive. It usually presents as a firm indurated plaque on the lip. And you treat it with Mohs, but it has a high local, and you treat it with Mohs because it has a high recurrence rate with wide local excision. And the stains for this are CK15 positive, CK7 positive, and EMA positive. Okay, next one. So this is forming like a little cystic space, and the wall is just like 1 to 2 cuboidal cells. So this is a hydrocystoma or hidrocystoma. So it's lined by cuboidal cells, and you can have multiple in Schaaf-Schultz-Passarge syndrome, which they ask about on practice questions. Okay, next one. So the big thing here is you have this nodule, and you have some basaloid cells, but you also have some areas that look like cartilage. So when you get a mix of two kinds of tissue, it's a mixed tumor or chondroid syringoma. So you have sweat ducts, but then you also have more like a cartilaginous differentiation in the stroma. And then you can also even get bone formation in this. So clinically, they're slow-growing solitary nodules that are very nondescript. Some of them have PLAG1 rearrangements, and they arise from the myoepithelial cells lining sweat ducts. So it's a 50-50 mix of epithelial and stromal components. And they are positive for SMA, S100, and SOX10, and you can treat it with excision, but they're benign. There is a malignant form of mixed tumor, though, and you would just see more atypia in that. There's two different types of mixed tumors too. There's the small tubular type and the branching alveolar type. So here's a picture of them. So the branching alveolar basically is kind of what it sounds like. It's more branching, and the small tubular, you really have more of like those tubules. So it's pretty self-explanatory the difference between the two. But they both have a mix of different features. Okay. So this one, we have a pretty normal epidermis. And then we have these cells coming off of the epidermis, um, like forming a tumor here. So, and they're pretty small, monotonous cells. These are poroid cells, which are cuboidal with ample pink cytoplasm. So this is a poroma, and it connects with the epidermis. most commonly found on the foot, and it's an endophytic growth. Um, and then variably sized sweat ducts containing a pu pink cuticle are seen, and there's a lot of vascularity in the stroma, which if you've ever seen these clinically, you know that they look very friable. So that makes sense. Oh yeah, okay. So they're solitary vascular appearing nodules that may ulcerate or bleed. And they're most commonly on the palms and soles because that's where there's the highest density of eccrine glands. And then they are CEA, EMA, and PAS positive because they're so glycogenated. And then there's some different variants, which we'll see in a minute as well. So this one kind of looks like those poroma cells, the poroid cells, and you even see like a little duct forming here. But it's all within the epidermis. It's not coming off of the epidermis, it's just like in there. So this is a hydroacanthoma simplex, and this is the Bohr-Steenson effect. So basically, like you see this like the basal cells are very distinct from the proliferation itself. And you can also see that in clonal SKs and Bowen's disease. So just the intraepidermal version of a poroma. Okay. And then again, we have these poroid looking cells, but they're only in the dermis. It's not connected to the epidermis at all. So when that's true, when it's just dermal, you call it a dermal duct tumor. So poroma, hidradenoma, simplex, wait, hydroacanthoma simplex and dermal duct tumor are all kind of on the same spectrum, just has to do with where it is in the skin. Okay, next one. So you have this proliferation of basaloid cells in the dermis, um, just kind of forming a nodule. This is nodular hidranoma. So you have the cuboidal cells with ample pink cytoplasm, and then you have an area of cystic degeneration, and you may have like a focal epidermal connection, but you might not see that based on the cut. And there's a lot of dermal sclerosis around it as well. So like down here especially, you can see that the collagen is pretty thickened. And then this is like the cystic degeneration that they're talking about. I always find this one really hard, but um, it kind of has that like frond type architecture too. But it's really forming more of a nodule. Okay, and usually clinically, it's a solitary nodule with a deep red purple hue. And then there's a malignant counterpart too that has more mitoses and atypia of the cells, and you treat that with Mohs. Okay, so this one similarly has those cuboidal cells with ample pink cytoplasm, but it also has some of these clear cells. So this is a clear cell hydranoma. Um, So this can sometimes have a T1119 translocation, which is good to know, but otherwise it's pretty similar to the nodular hidranoma, just has some of those clear cells in it. Okay, so again, we have little sweat duct cells, but they're forming large open lumen. And so this is a papillary eccrine or tubular apocrine adenoma. So it's hard to distinguish those, and there's a little bit of controversy with that. But you have these dilated duct-like spaces and blue papillary projections into the spaces sometimes. So if you look in this picture, see how it's kind of projecting there, or here it's kind of projecting. So other factoids about this. So eccrine is most commonly seen on the legs in Black women, and apocrine is most commonly seen on the scalp in association with a nevus sebaceous, and that one has decapitation secretion as well. Okay, last one. So this one has a central invagination here, and you have a lot of smooth muscle in the dermis. So this one is a supernumerary nipple. So, or an accessory nipple. So you have a little bit of epidermal thickening. You may have a little bit of basilar hyperpigmentation. You can have like you do have it here, like more of a papillomatous architecture of your epidermis as well. And you just have like a lot of smooth muscle around. So those are the main things that you look for that. They like to ask about this one too on practice questions. So that's it for now, and we'll be back with another one soon.